C-reactive protein, or CRP, is one of the most commonly requested tests in both hospital and general practice. There has been an increase in its use that cannot be completely explained by escalating rates of disease. CRP was named in 1930 for its ability to precipitate the C polysaccharide of the strep pneumoniae and plays a key role in host defenses against infection. It is produced in the liver in response to inflammatory cytokines, especially interleukin-6. Increased levels are seen in inflammatory conditions. Conditions that raise the CRP include inflammation, infection, necrosis, trauma, malignancy, allergic reaction. Baseline levels can be affected by several factors including age, gender, smoking, obesity, and lipid levels. It is not affected by the time of day, food, or medication, unless the medication influences the primary disease process. Within individuals, the CRP level remains highly conserved in the absence of acute inflammatory insults. Its production is impaired in severe liver disease. This synthesis of the CRP is initiated by antigen immune complexes, bacterial infection, fungal infection, trauma or tissue injury. CRP is an acute phase protein, raised in the inflammatory diseases, and its level increases tremendously. It is raised in acute and chronic inflammation. This promotes the binding of complement and helps in the phagocytosis. CRP is extremely useful as a marker of acute inflammation because it increases by a large margin within a short time frame. Its production is upregulated within 6 hours of an acute insult and can double around every 8 hours. It peaks at about 48 hours after the original stimulus. If the cause of inflammation is addressed, it decreases very rapidly at a speed which reflects its normal clearance rate. The half-life of 19 hours appears constant, so the only determinant of CRP concentration is its rate of synthesis. Although infection is more likely as the cause of a very high CRP, it is not specific, and high levels may also be seen in autoimmune disease and malignancy. CRP performs poorly as an accurate marker for bacterial sepsis. In a recent Swedish study of over 1,500 critically ill adults with verified bacterial infection, the CRP positive predictive value for sepsis was around 11% and negative predictive value of 90%. Lactate performs better than the CRP in this clinical setting and is therefore the recommended marker in the National Sepsis Pathway. CRP may help predict prognosis in severe infections. A prospective study of 191 adults with community-acquired pneumonia in the ICU demonstrated a 5-fold risk of death and increased risk of multi-organ failure in those patients where CRP did not respond within 5 days. In this study, CRP was tested at 48-hour intervals. There is no published evidence to support a daily CRP measurement. Critically ill patients are also more likely to have non-infectious causes of CRP elevation, which confound the interpretation of the result. These include deep vein thrombosis and transfusion of blood or blood products. The Choose Wisely campaign recommendations state that a daily CRP should not be requested as a measure of response to antibiotic treatment if patients are clinically improving. Pathology test numbers are very high in the emergency department, a key area for identifying patients with infections to start treatment. The Australasian College of Emergency Medicine and the Royal College of Pathologists issued a joint guideline for pathology testing in the emergency department in 2018. In general, CRP is not recommended as a routine ED investigation in this guideline. Common presentations where a CRP may be considered: severe atraumatic back pain requiring admission, fever, or suspected septic joint. As mentioned previously, lactate is the recommended biochemical marker in suspected sepsis. It is often incorrectly assumed that elevated CRP is completely accurate in identifying patients with significant illness, and conversely, that a normal or low CRP is completely accurate in ruling out disease. This assumption leads many clinicians to assume that excess testing produces no harm to the patient. However, a community-based linkage study of over 160,000 patients who had CRP tested showed a slightly different story. In that study population, for 42 true positive results, there were 236 false positive results, leading to unnecessary anxiety and cascade investigation. Similarly, for 679 true negative results, there were 43 false negative results, with the potential for delays in diagnosis and effective treatment. The message here is that no test should be interpreted in isolation from other important clinical indicators. A local increase in test numbers demonstrates more patients are having repeat tests at intervals of less than 48 hours. Data that was not included in the previous result was critically abnormal, over 200 milligrams per litre. This breakdown of repeat testing in 2019 varies between each of South Australia's public hospitals. In summary, CRP is an extremely sensitive marker of inflammation, but it lacks specificity. As is true of any pathology test, CRP must always be interpreted together with a history and examination of the patient. It is one piece of information, which is not able to tell the whole story. There is no clinical evidence supporting a retest interval of less than 48 hours in patients who are clinically stable or recovering, and lactate is a better marker for patients with sepsis. Further information is available on the Choose Wisely Australia and Lab Tests online websites for both clinicians and patients. The SA Pathology On-Call Pathologist is also available by phone at any time to discuss the requesting and interpretation of test results. Thank you for watching.